Cancer has touched my life in very personal way. I lost my daughter in cancer 2006. Tina was only 24 years old and left behind the love of her life, her husband and her two young sons as a 2 years old and Dom is a 2 months old. The cancer that took her is called choriocarcinoma. Choriocarcinoma is a rare type of cancer that can affect women who have recently been pregnant. It can occur after normal birth and as well after miscarriage or abortions. In choriocarcinoma, something seems to cause the cell at the site of inflammation. From the pregnancy to start going haywire, ultimately metastasizing through the body. It is detected early, the condition responds well to treatment and usually is infallible. However, there may not be obsessive symptoms associated with the condition other than SCG level that do not return to normal after the pregnancy. An easy way the moms to screen themselves for condition is it to take home urine pregnancy test 21 days after giving birth. If you do get a positive test, then go to doctor as fast for checkup. Instead for the being seen. If you get a negative test result, then you should be healing just fine. So I share this information and I hopefully help others in hopes of separating someone the pain I live with each day in my heart. I miss my daughter so much. Thank you.
More from our news anchor Adave.
Tina story, May 18, 2006. Tina passed out without explanation. She was transferred by ambulance to the hospital and was unconscious for over 6 hours. From there, she was med-flighted to Stanford. Stanford sent Tina home on Sunday, the 21st, without doing any tests to determine the cause of her collapse. The only explanation they gave us was an opinion. They told us she suffered from conversion disorder, meaning the brain did not know how to handle stress. And in their opinions, she needed counseling. Tina's husband, parents, and family knew that this was not the right diagnosis. However, they figured these were professionals and they must know what they were talking about. While at home on Monday and Tuesday, Tina tried to rest as much as possible. She went shopping with her sisters, cheered for her husband at his ball game, and took care of her two boys. She was trying to function all the time. She was in a lot of pain. On Wednesday morning, she was feeling very badly. Her mom and sister took her to the hospital again. Luckily, our doctor that Tina was placed with turned out to be fantastic. The moment Dr. W saw her, he knew that something was wrong. It was stunned that Stanford had not done any testing, not even a lumbar puncture. So he ordered one right away. The test revealed Tina's brain was bleeding. As Dr. W was ordering neurosurgery to be done, Tina began convulsion and went into a coma. The pressure changed in her spinal column and caused the change and went into a coma. The pressure changed in her spinal column and caused the change of pressure in her brain and thus caused further bleeding. Tina was immediately moved to the ICU. She showed signs of improvement on Thursday morning in response to the neurologist test. However, later that day, her brain began to swell some more, and she slipped further into her coma. On Friday evening, two different neurologists performed several tests to determine the condition of her brain. On Friday, May 26th, her family was told she was completely brain dead. Tina was kept on life support so her organs could be donated, as this was her wish. At this point, her family did not know the cause of her death, other than knowing she had a large aneurysm. The family received their answer when the organ donation center called on Saturday morning to tell her that Tina's organs could not be used because she had cancer. While trying to deal with the shock, the family was informed that Tina had suffered from a very rare form of cancer that started forming in the uterus after a miscarriage, abortion, or live birth. It happened to any woman at any age. So what happened? Choriocarcinoma. This particular cancer happened with the ones that are actually intended to ill attached to a cancer or germ cell in the uterus. In fact, you should know, choriocarcinoma is treatable. It gives a false pregnancy test results and raise your HCG levels. Human chorionic gonadotropin about 15 to 20 days after you have a baby. Do any method. Your HCG levels should be back to normal, showing a negative reading of pregnancy test. If the cancer is caught early enough, you have a high chance of survival. This cancer responds very well to chemo.
And now from our scientific professional, my mom.
Choriocarcinoma is a rare, aggressive neoplastic type of trophoblastic disease. The two major types of choriocarcinoma are gestational and non-gestational, and they have very different pathophysiology and prognosis. Choriocarcinoma predominantly occurs in women, but can also occur in men, usually as part of a mixed germ cell tumor. Choriocarcinoma develops from an abnormal trophoblastic population undergoing hyperplasia and anaplasia, most frequently following a molar pregnancy. There are two forms of choriocarcinoma, gestational and non-gestational. Gestational choriocarcinoma arises from a hydatiform mole, normal pregnancy, or most commonly, spontaneous abortion. Non-gestational choriocarcinoma forms in males or females in the gonads or midline structures with pluripotent germ cells. The exact pathogenesis of choriocarcinoma has not been fully explained or understood, but studies have shown cytotrophoblastic cells function as stem cells and undergo malignant transformation. The neoplastic cytotrophoblasts further differentiates into intermediate trophoblasts and syncytiotrophoblasts. The healthcare professional should conduct a thorough history and physical examination of any patient with suspected choriocarcinoma. In women, clinicians should pay particular attention to reproductive history because spontaneous abortions and molar pregnancies increase the risk for choriocarcinoma. One should consider postmenopausal bleeding suspicious. Choriocarcinoma tends to metastasize, and clinicians should note symptoms that arise from other organ symptoms. For example, hemoptysis or gastrointestinal bleeding. Due to elevations in HCG levels, patients can present with abnormal uterine bleeding, gynecomastia in men, or hyperthyroidism. Males can present with symptoms of metastatic disease, often hemoptysis, but the liver, GI tract, and brain are also frequently involved. A low risk and stage 1 to 3 choriocarcinoma can be treated with a single agent, either methotrexate or actinomycin D chemotherapy. High risk and stage 2 to 4 disease are treated with multi-agent chemotherapy, adjuvant radiation, and surgery, following treatment and HCG normalization. Quantitative HCG levels should be checked monthly for 1 year with a pelvic exam twice in the same time frame. If a subsequent pregnancy occurs, first trimester pelvic ultrasound should be performed to confirm uterine location due to the small but present risk of recurrent choriocarcinoma. The placenta should be submitted for histologic examination of recurrence.